practice has been for almost like 30 years, is that when you come back in about 4 months, when you first start doing this, you're going to find that you've got all this open time on your schedule. So what we're going to start now is we're going to show you how we take the impressions. One of the first things you want to notice is that once in a while the multi-unit won't be inserted, so it's real critical that you look at the Panorex or single X-rays, but make sure every single multi is down, because you only do it one time. If it's not down, the first time you do the first recall, you'll find you'll have to do the whole restoration over. So first thing, let's make sure the multis are down. Now you're going to see the ease of this procedure. We're going to take off the temporary protective caps, and then we're going to use an open impression technique with a Miro tray that you'll see how easy it is to use. We've done over 1,000 bars with this technique, and we've never had not one bar not fit perfectly. So let me show you this first step. Now open real big, and so right now I'm just going to take off the healing cap. This procedure went really well. Sometimes if you've got a little swelling of the tissue, I like to take off one cap at a time and then put it on. And I'm working without my light. Let's see. Hold everything closely. You don't want to swallow one of these, so I always try to use 2 hands. I'm kidding you, but you'll be amazed. I've never in my whole career ever had a patient swallow anything. Open real big. I don't want you to be the first, but one of the ways, you'll be surprised when I've been out training dentists, open big, big, big. I'll see people with one hand doing this, and you don't want to do that. So here comes the second one. One of the things this is an easy procedure to do, but it has to be done extremely well. And so you want to check everything you're doing. So you're going to see when we get done, open real big again, that we're going to check X-rays, which is real critical. This is an easy surgery because everything is basically sub-G. But a lot of times, the reason we use all on 6 is because all on 3 doesn't work. And we don't want to do this procedure over, so it adds a little bit to the cost of the procedure, but it gives us a lot of redundancy. And then also, by having 6, we're spreading the load out from the beginning. Now, one of the tricks, if you see, I've done 3 over here, and so you can keep going this way, but these posts are so big, they get in the way, so it's easier to go to the midline and then open real big again, and then I like to go to the very most posterior healing cap, real big. I usually use a light. And so we're coming back again, real big again, please. There we go.
So you helped create this concept, and with the communication with the lab, do you find that to be the secret sauce here in your lab that you guys have set up, and the way that the workflow is?
Yes, this was really, we spent 4 years developing this, and basically Dan and I have lived at that lab for 4 years. And so this is the 4th generation, totally reinvented if you came here 4 years ago. So since the lab is right down the street from my office, I basically, when I get off work, one of the things I do is I check all my design cases. So when the designers are working about 4 o'clock, and then I basically check my designs right before I'm going home. We have an app for our providers if you want, but our designers are so good you don't have to. But when they finish the design, stay real still. We send you the design on our app, and then you can say some providers do, some providers don't. You can be the final okay, or do you want any other work done? So it's pretty neat. So what's made this procedure is, again, you can see it's also, there's some pre-work that goes into this. So one of the things is you want to find out what the patient wants. So basically we have another computer app that shows different styles of how the teeth can look, and it's very easy to use. You start in the centrals, you digitally show patients multiple ways they can look. So it's designed to look at the face. If you've got a square face, square tapering face, oval face, then once we pick the central, then we go to the lateral, and then we can come back and like mix and match. So you can actually, you could have a square central. So you can see that took what, 5 minutes, 6 minutes. The down. Now what's critical now, we're going to take check x-rays to make sure these are all the way down. Again, do not ever forget the step for taking the check x-ray to make sure the open tray is down, because if you get a slight gap, you're going to get a slight gap in your bar. So it's real easy. We're going to take some check x-rays. Oh, we're doing perfect. You can see, if you can see in the camera, those are down. Again, what can happen, this surgery, all the multis are super gingival, so this is very easy, but sometimes they're not. And you can screw these down and you'll get a little gap. They'll feel like they're real tight, but they're not all the way seated.
Period.
No, you know, what we found is that about 10% of the patients, when we do the first recare, which is taking the restoration off and cleaning it, about 10% of the patients need a little bit of material added. And it's very easy to do. You can either do it at the chair, or you can take a closed tray and press in. Our patients, when we do it at 9, they come back after lunch, and it's totally done. So it's very easy to add, but 90% of the patients don't need that procedure done.
Wow.
So now this is what really adds accuracy to this. So we've got the open tray, and this is basically, this floss technique is acting as a verification jig. So open real big, where you go to the most posterior implant either side, and this floss is always a pain in the neck. Hold that down, please, Maria. And then I'm going to come back right under the neck, like that. And then I'm going to tie it off, and I'm just going to wrap it around 2 times. But what this is going to do is we're going to lute this together with a resin, and this is going to give us a rigid one-piece impression. And again, from doing 1,000 bars, we have literally never had one bar that when you look at the x-ray isn't perfect. Now part of that could be because we've had the top people from BioHorizons down, including the co-inventor of one of their main implants, and they spent about 6 months checking this technique before endorsing us as an alternative to Teeth Express. Is that when you have unintegrated implants, you could technically move the implant into place the next day or 48 hours later. What also one of their chief research people was talking about, what they were impressed with, is by adding the titanium bar and the rigidity that produces, that it really increased our success rate over traditional teeth in the day procedures. And what it also allows Dr. Northwick to do is, if he does 6 implants and he puts 4 in that are stable, he'll go in and do a lateral lift or a full sinus lift, and the posterior implants that are not stable, they become stable when you put the titanium bar in, which distributes the force way better than a traditional plastic interim temporary. And that's why we have virtually a 99% success rate from doing this procedure. That's what they think. It's the titanium bar is really increased. Okay, so I want to show you 2 techniques. What we're going to do is we're going to lute this together, and there's 2 really good ways to do it. You can use Luxabite. Luxabite is a dual cure, it's a cure just with a catalyst. So let me show you one way you can do this. And so you just very gently go over, and you're coming around. I like using this on crown or bridge on larger reconstruction cases. The only thing is if you get too much, you can't salvage the day by hitting it with the light real quick. So this is one way. I'll do half one way, and then I'll show you another way in the other half. They both give you really good results. So you see how fast this is. It takes longer to set, but you have the ability to light cure it. So let me show you the other way. This is the way we originally did it. My partner likes the Luxabite. I still have a tendency to use this more. Now at the lab, when we place the analogs, we're coming back again, and we're using this floss technique. on the analogs because we want super rigidity, no motion. Okay. So you can see we're at about 10-15 minutes into this procedure at the most. We've got the impression post on, we've got the rigid bar. We're literally ready now for impression. So one of the tricks with the impression material, it's no big deal. I like to put wax in the access holes. Makes it a little bit easier to get out. Now, one of the things, when you use the Miro tray technique, there are only 3 sizes to pick from. So you want to try the tray in, and you want to visualize where the impression posts are going to come out of the Miro tray, so you know you have the right size tray. And so one of the things too, that how we digitally transfer information, and if you want almost no reprocessing or re-adding to the material, you're going to come back and imagine about the old border molding technique. So when we try the tray, open real big. So I'm coming in, and you can see, hopefully with the camera, where this is a perfect size tray. Now, one of the things we want to pick up that helps transfer the preoperative data from the face hunter and the plane finder, and if we also don't want to come back and have to add material, we have to get a good impression in the buccal fold. So we're going to come back and use heavy body in this tray because we want total rigidity. Don't use medium or light body, you want heavy body. And I'm going to come back almost pretending like visualizing I'm doing old border molding on a denture. I'm coming back with the light viscosity. I want to pick up this whole fold, including, if I can, the retromolar pads, and you're going to see how I squirt the light body material under here because I want to pick this all up. If you pick all this up, you'll almost never have a reprocess. So in this procedure, there's 2 main steps. It's the impressions, it's the bite. It's critical that you're doing this at A level. You can't be sloppy on this technique. You can't skip checking that the multis are down. You can't skip that the open impression tray is down. You want to make sure that this is luted together really well. You want rigidity in this, and we want to make sure we pick up the folds, and that's how, when we're stitching together information, we need that data.
Now, how many of these arches have you restored?
My partner and I, well, we've done over 500 and something patients and over 1,000 arches.
Okay.
Here we go. So hold this up, and I want to really show this. So this is critical. I'm coming back. I want to pick up the retromolar pads. I'm coming all the way around. I'm coming up under, and I'm squirting under pressure, and I'm coming back and picking up the whole fold. So here we go. This is a mess. Real big. Stay open, please. Stay open real big. You're doing perfect. We've got 3 minutes. Now, you see how I'm massaging this in? This is just an old denture technique. You're picking up the folds. This gives a way better impression. When this is setting, we're in great shape. Open real big again. Real big. Okay, we're there. Make sure that you count all the open tray impression post, because if you don't have them out and it sets, you're going to be working to get this tray out. So one of the things that makes this procedure possible is this has been thoroughly beta tested. When we did this procedure 4 years ago, when we did this procedure, it was based on a biocopy technique of where we set denture teeth. Then we came back and we would bioscan it. And what that meant was that we didn't have the same accuracy of midlines. And when you scanned the denture teeth, you couldn't come back and change them or customize it. So what's unique about this restoration, this is truly 100% custom-made digital ceramic bridge that's milled to about a 30 micron fit over the bar. So the material itself is really unique. It's a nano ceramic. The material was actually tested for 2 years, and it was so strong they thought you wouldn't even need bars. After about 2 years, there were some small micro cracks forming. So when we added the bars, and the company added the bars, there's no fracture problem. So it's a really neat material we're using. We're actually prototyping, which will be out in about 6 months, of material that's even stronger than that material. So the nanoceramic we're using now is a 70% ceramic by weight, 30% by weight resin. So it's setting now. About another minute or so, we'll be taking this out. So again, this procedure has been thoroughly beta tested over 4 years. And so the last procedure, we totally rewrote the software. And so what's making this possible, we're actually, by using the face hunter photography, what we're actually able to do is we can skip the try-ins, because before you needed to know where the midline was. So if you were used to an old zirconia technique, you were basically using a wax try-in of a denture, and when you finally got it right, you would scan it. So how many times did that take you 2 or 3 visits just to get the wax try-in right? So what's unique about this procedure is that it's basically a wax rim denture technique that we digitize, and then when we superimpose on the pre-op data, we're able to look at the can of the teeth, the midline of the teeth, and so we get incredible midlines, cants, and then the software, if you give us the right records, you'll almost see that it takes me on an average 5 minutes. I spend 10 minutes at the most adjusting these on the day of insertion. I like to see the patient the next day or the second day after when the muscles relax. You know, I kind of spot it in a little bit more. Post-op visit a week later, and then basically we're almost done with the procedure. I like to maybe see a patient a month later to see how they're doing. So what's amazing about this procedure, if you're doing this done in one, is you're going to be able to do these 2 steps. You will digitally scan us the data, and then we like to recommend, we had one of our first accounts, FedEx guarantees it at 10:30 supposedly, and they scheduled one of their accounts to patients at 11 o'clock. So we recommend give FedEx about 3 hours, about 1 o'clock, something like that, and we found that we have no problems. Now, part of the program, when you do done in one, it's real key, but it's not just key, you can't do it without it, is we need one person in your office that we train to do the model work, which means you have to be able to pour up this model very accurately and quickly, and then you have to make the bite rim, and then that person then is also trained to scan the data in. It takes about 1 hour to scan an upper and lower arch. It's actually very easy to learn how to scan. What we found from training other offices is that if you have somebody like a very good assistant that's used to model work, we can usually train that person in a week. If you have somebody, we've trained somebody that had no dental knowledge and didn't know what dental stone was. We did it as an experiment. It took about a month. So we need somebody, hopefully you have somebody in your office that's been with you a long time, stable employee. You can train to do it yourself. But now, let me show you this. This is what gives you, I'm going to give myself a grade A on this impression. You see how I've got the buccal folds? This means that when we make this restoration, they know exactly how to make the flange. I can almost guarantee you this will be a perfect fit. There'll be no reline in 6 months if you give somebody this impression. So what I'm going to do is rush this. You want to put the protective caps on, and I'll get this to the lab. We're going to I'm going to give this to my lab tech. They're going to start pouring this up, and then we'll go to the top.
Get that much.
Okay. Oh.
Camera,
Oh. Oh. So you know what? Maybe you should give that. Okay. I won't do that. My assistant will, so we don't go offline. Let's see. Excuse me. All right. Well,
all tangled up.
all right. Let me get some new gloves. So Marina's given that to my lab technician. I'm going to go right to the top.
So your lab works around the clock, 24 hours,
Yes.
and you're able to deliver this same result of 48 hours to anyone in the U.S.?
Yes. You know, in my office, we're able to deliver and insert the next day. But around the country, it takes one more day. But what's pretty amazing, if you're comparing like yourself, benchmarking yourself to Clear Choice, or it's how we did it for 20 years, you would be right now at the end of the day maybe inserting a temporary, and then you'd be coming back in 3 or 4 months, and then you'd be spending anywhere from probably about 9 visits to make the final. Well, you know, I've been doing hybrids since, it's kind of neat. I did a hybrid on my mother in 1990, And it just shows you the technology, how it's progressed is amazing, because we had to take the teeth out, wait months, put the implants in, wait months. It was about teeth in about a year. Open real big again. So again, put some gauze in. We don't want to lose any parts. Now I'm going to take the healing caps out again. So what's really neat, what makes this procedure possible, there's 3 distinct teams that work on this. So what happens is we want the data, especially in a double arch, we like it scanned in approximately by 4 o'clock. The designers come in and they work, it takes from about 4 to midnight, hold the lip out please, about 4 to midnight to have the data or the design done. And then what happens is the milling team is coming in and they start a little bit earlier, about 11. And so there's a part called CNCing where you've got to be able to open real big again, please. And this is the one I'm talking about, suction there. It's the hardest part of this, I don't have my light on. This impression post is a little temperamental, and if you're slightly off, it doesn't go in. So I'm glad we saw this. So you see how this one is sub G, but it's in. But this is the type that can fool you. It looks like it's down, but when you take a check x-ray, you could have a gap. So again to the lab, once the bridge is designed, then the milling center mills the overlay, and it starts milling the bar. There's multiple machines going. And then what happens is it takes about 2 hours to cut all the sprues off and then actually put the restoration together. And then what we do is that's starting to get a little sore. I'll give you a little bit more anesthetic in a second. And so what happens is by our ceramic team comes in at the crack of dawn, and then if we're doing 2 arches, then 2 ceramists work in tandem. And then that's how we're able to insert or basically give almost any place in the country that has FedEx or UPS the restoration the next day. So it's 3 distinct teams. Now what's unique about the design, this is a truly 100%, and we say that because there's different places that have tried to make shortcuts doing this. We make no shortcuts on this procedure. This is 100% custom designed teeth. And what that means is that there's 2 ways you can make this. There's one big company that sort of does this, and their technique is they literally pre-make teeth that have no relationship to the patient. So imagine if you had like small, medium, large, and you had your milling machines milling different styles of teeth. And what you did is you put it in hollow grind mode so that if you looked on the underside, the whole restoration is like basically, it's just like a thin veneer. So what they actually do is then they take an impression like this, they mill a bar real quick, very low profile, because if you haven't designed the teeth custom for the patient, open real big again, please. And you can see here, this is what happens after surgery, the collar swelling up a little bit, real big, please. And so look at the angle, again, this is the only thing on this that's a little temperamental. If the angle's open real big again, big, 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 that's it.
From the restorative side, are there certain limitations with different implant systems on the restoration solution, or is this universal to all systems?
I believe that only one we can't do is Straumann. Straumann's got a thing where they won't give you their scan bodies. We use BioHorizons. We've had incredible results using BioHorizons implants, especially their new implant that's got very aggressive threads. And then we really like, which we use on our crown and bridge, we really like their laser lock coating because we really think that the tissue bonds to it quicker, open real big. So we don't want to take any shortcuts. Big, 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 please, real big. But at Nobel, any of the major brands, we've got everything for the multis. Now, one of the things why it's coming soon is at the very end, when you do this procedure, we need the impressions. We need the impressions to do the final undercoating. So when you would get done with this, after the models are done, you FedEx us, you digitize all the data, and you FedEx the impressions that we need in the morning to do one last about an hour's worth of work. But what BioHorizons has almost got finished for us is we're going to have linear, I'll give you a little bit there.
No,
It's oh, we're just holding that up so we don't, I'm sorry, just go real light, open real big, almost done, is big, big, big. They are now making the replicas for us, especially for us, open real big again, where we're going to be able to 3D from the replica print the model of this. Now, the nothing is actually milled off of it, but at the very end, to put the final surface coating on, we will be able, hopefully just within 2 months, the way we were talking to him last week, we'll be able to print, open real big again, print the models. So the advantage of that is if you're using the BioHorizons implant system, okay, cut that end. And now we're just going to come up here to Explorer, please. Open real big again, please. There we go. Hold that in. Press that. Okay, here we are. Open real big again. There we go. There we are. We're just coming around again. Hold it right there, please. There we are. Real big again. Now, one of the things we like, if you notice, is conscious sedation. So when we go, whatever procedure you use on sedation, is the patient, we want a little alert when we go to do the bite records. And we found if you're not careful with IV, that the patient is not alert enough. So we do like 95% of these procedures under sedation instead of IV. That's just a nice tip. I think you'll find it's a lot easier to do. Okay, we're ready to go. Let's do Luxabite. Let's start off half and half again. So again, this is the material that's not light cured. Luxabite, open real big. We'll loop that together, come around. Again, use plenty of it. We want this really luted where it's not moving. Make sure you get the linguals. And then I'll come around. One of the tricks is if you squirt too much, it'll go too far to the gum. But it's easy. What you do is you just get a burr and then you just trim it, because if this material was to hang down by the gum, you're not going to pick that up in the impression. So it's very easy to trim that with a diamond. Actually, I'll just do the whole thing. And then you want to use, hold it, I've almost got it done. Let me just use this. It's quick. Open real big again, please. There we go. Let me use the triad, please.
When do you remove the sutures?
The sutures are dissolvable.
So you just let the
They just come out. We don't. You know, I'll tell you what, patients. I tell patients from doing this. I always tell patients to give themselves, especially if it's an extraction case, about 4 days. So from doing teeth in the day for 25 years and doing this, is that, let me get that off, is that if you just come in and basically say, I'm going to come in, give myself 4 days to take it easy. Almost every patient we've ever done is able to go back to work the 5th day. A lot of times even the 4th day. You'll see, you're here tomorrow watching this. how the tissue looks. It's sore for usually a couple weeks, but again, most people, virtually everybody, 5 days, do what you want to do. Let me cut this off, please, over here. One of the things is we like doing this freehand. We used to do a lot more guided surgery, and the problem with the guided, I think Dr. Northig was talking about that, is when you do these full flaps that guided, wants you to do, you get a lot more post-op swelling and bruising. And so on the hybrid bridge, what we really care about is we want about 13 to 15 millimeters of reduction. Imagine if you had a Fox occlusal plane. So one of the tricks is you don't want to just remove bone here, but you want it on the correct plane, like if you're doing a face bow. And so since that's what you need, open real big again. I just want to try the tray. Open real wide. There we go. You're almost going to get a nice break. So again, what I'm looking at is I want to make sure that the impression posts are coming through the tray. I'm picking up the buccal fold, which I am. This is a great tray. Okay, we're ready to go. Oh, so to go back, what's neat about this surgery is again, I've done maybe 3,000 arches, teeth in the day. If you look at post-op complications or swelling or bruising going freeform versus guided, especially with the bone reduction, because of the flaps that are required, patients love it when you do it this way versus doing the guided way. And then also, when you're doing the guided and you're doing the full flaps, it's very hard to come back with the bite rims when you've got all the swelling that's already happening the way the tissue is handled. So again, this is basically, it lowers cost, but it gives you a better result. You can see how Dr. Northig does it. Basically, it takes him about 2.5 hours on average to do an upper and lower surgery. And then it takes me about 2 hours of time. So you're really about 4.5 hours time. It's a lot better for the patient again. If you just compare swelling the next day, bruising, if you say, what's your pain on a scale of 1 to 10, it's usually dramatically less when you don't do guided, especially if you're doing the full flap.
Very interesting.
It's real big. I'll give you a little bit more anesthetic while we're waiting. Okay, so, so we're going to wait 3 minutes. This is coming out really good. We've got perfect implant placement. So, what led me to develop this, I heard Dan talking, is if you were in old school where the frontal restoration, you're using denture teeth over the bar, if anybody's experienced doing this, no matter what you try, what kind of denture teeth, the denture teeth are always breaking off. What usually happens within a year to 2 years at the most, the posterior teeth wear, then you start hitting the anterior teeth and the anterior teeth start popping. So that's the big hallelujah moment making this. If it took 6 months to do this restoration, you're getting a gorgeous restoration, and it's a one-piece nanoceramic bridge. There's no weak link like with denture teeth breaking off. So that's what we really like about it. And on aesthetics, I heard Dan talking about zirconia versus this. You can get great aesthetics with zirconia if you go to the master level. So we have an account in San Francisco that we do all zirconia bridges that wants literally from second molar to second molar all cut back. And we're cutting back where we're leaving like 1/4 millimeter at the incisal edge. We'll have a ceramist spend 2 weeks just doing that procedure, and he doesn't care what it costs. Now, if you do it that level, you can make a gorgeous zirconia bridge. Problem is they still clink. So if you've ever heard an upper and lower arch with zirconia, it's basically a metal. If you look on the periodic table, it's not a ceramic. And so that's the big advantage of this restoration. There's a little give to it. You can actually easily bond to it if you get a chip. The other neat thing is this restoration is totally warranted by our lab for 5 years. So all the data that we spend doing this, we save in a special server. So if a patient literally fell on their face and broke a tooth, you call it, and our milling team that night literally will be milling the overlay because we've saved the data. And so you can either ship us the restoration, or we can actually mill the whole restoration over for you again very quickly within 48 hours. So if something disastrous occurs, your patient's in an auto wreck, we can quickly accommodate them with another restoration. And again, this is totally warranted for 5 years.
That's something unique as well. A 5-year warranty.
Yeah.
You don't typically see
Yeah.
that.
That's how we are with our patients too. I mean, I tell patients and we mean it, you fall on your face, we do it over again. But we've done this here for over 25 years. But the good news is these restorations are really, really strong. You know, the other neat thing too about this restoration is I keep saying it's 100% custom design. And that means that you also have the opportunity, if a patient really likes the way their teeth used to look when they're 20 years old and they give you a picture of their high school yearbook, we can virtually copy it because this is not cookie cutter. Open real big again, we're done with this. So you can see now I'm just unscrewing this and then we're done with phase one. You know what we can do if we don't want any more anesthetic? I put some numbing gel, load it up with numbing gel, making the trays. What's happening, your next step is really easy. We're just taking some bite records and you're going to go home after that. And we're almost ready to take this out. So again, on this impression, one of the key things to remember is when we stitch the data, we want the palate. It really helps. Also remember, you want to get the buccal flange. So you saw how I took the light viscosity and went around the flange. So, look, bragging on myself again, but this is exactly what we need. Got a little bubble there, we'll fill that in with wax. But this is what we really need in here because the restoration is going to end like right there. We really make these hygienic where they taper into the tissue so they're easy to clean. So we're ready to go. So Marina, I'm going to give this to the lab, and then now what we're going to have is we're going to have about a 40-minute break while we make the trays. Are you hungry, Elwood? You want a little snack? And so what I'm doing now is unscrewing this. And one of the things, do we have the Teflon tape by any chance? That was a neat tip. You know, can you find if we, yeah. This one is, it's the screw that won't come out. You got a hemostat. So this doesn't usually happen, but we get the screw that doesn't want to come out. Okay. And I was going to show you a neat little tip Marina's going to find. So when you go to melt the bite rim, the holes close up. And so, I don't know if we're out of it, but if you put Teflon tape in it, as you melt down, the Teflon tape goes in the access holes. You'll come to the Teflon. It just makes it easier. You don't have to open up the holes. And we have the Perio Pro, please. Thank you. And make sure, one of the little tips is to make sure you take the screws out before you start doing the records, because as you melt the wax, they're hard to get out. Oh, excuse me. There we go. All right. So what I'm going to do now is just look for the screws, take your Perio probe, pop them out. And there's one in here. And then let me just come back and add a little Teflon. This is a neat little tip. It saves some time, a few minutes. Can you put that in there? You have cotton pliers. There we go. So you can see I'm just putting that in. Okay, if you put that in. So what I'm going to do now is I'm just going to go measure vertical just like you would for a regular denture. So let me come back in. And I'm going to put a couple dots. This is just how you were trained in dental school. Yes, they come off. Now, now open real wide and just close until you touch your lips. Don't even think. We're going to do that until you repeat it. Make sure you touch your lips. So I'm just measuring. Open real wide again, please. Close again real quick, don't even think. Let's see what we got. So we're dead on the money. One more time, please. Open real big. Close again, please. So you can see we're dead on the money. Then I like to give about 2 millimeters. Let your lip really hang down. So we have certain parameters that we train you. See how close we are? And you'll learn that when you're trained that a lot of times this takes very little work. Let your lip really hang down, please. Let it really droop. Now, what I like on a nice smile is I want the rim at least at the level of the lip to a little bit past. And so, again, the reason for that is then when the patient will smile, then they're going to show about 2/3 of the teeth. So I just want to get an idea where we're at. And then smile real big, please. Then I'm also looking at the buccal corridors. I like a nice buccal corridor. It gives you very good aesthetics. So we're pretty darn close. So now what I'm going to do is see with the lower bite rim how close we are on the vertical. See if you can put that one in. I'll hold the top and open real big. See if we can give it light. Usually I'm using the... Okay. And now close. No, that's fine. Now close your lips. I just want to get an idea where we're at. So where you can see that we're open. So let's see. Stay closed now. Smile real big. And we're showing too much of the bottom, so I'm going to start taking off some of the lower. Again, this is just like what you would do on Teeth Express. All on 4. Hold that in, please, Marina, and then I'll start melting. So what we've done is we've basically taken just a traditional, how you would make a nice custom denture, which is how you would make a hybrid or an all-on-4 or Teeth Express. But what the secret sauce is, we spent 4 years working on software. So when we take our preoperative photos, what we're going to do is take photos. Yours in, and I get mine. Open again. Okay, now it is. Now, bite all the way down. Perfect. Stay just like that. Nope, just lightly, like that. Tell you what I see. Open again. Let me take a bit off the front. Hold that top in, please. So this is basically, you just go back and forth until you get the bite rims that you need. Okay. And then put the low. Oh, you got the top. Let me get the lower in. Okay. 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 Lightly closed. Stay just like that. Yep, just like that. Okay, perfect. Close it. There we are. So, nope, that's it. No, stay closed. Close your lips just like that. So now we're almost at perfect vertical with the freeway space. So let me take a look. Now, smile real big. Yeah, tomorrow there'll be protective caps today, and then that's an interface that the bridge screws into. It acts like a stress breaker. Open real big. Okay. Sorry, you got that denture sore spot. There we go. Okay. Yeah. So I can give you a little bit of.
No,
Yeah.
it's all over.
Yeah, that's unfortunately, yeah, so I'm caught in this chair. Okay, so here we go. Now let me get you here. Let me get you. That's it. We got to make sure it's seated all the way, and that's why you got to have a little pressure. Now smile real big. So again, one of the tricks is I'm going to score this because I want to get a really good bite. And so you can see how I'm doing just nice V cuts, deep, because I want to really pick up a very accurate bite. And then we're coming back here. Again, this is just what you learned in dental school, doing dentures. Nothing's new. The only thing we've really changed is we can basically take this wax rim, easily scan it, and then we merge it with the preoperative data, and then our designers know exactly the cant, the midline, and I think you'll see tomorrow the occlusion is incredible on these. Okay, so here we go. Now let's get this in. So what I'm going to do is screw the upper one in. Over there. So I've got a little bit, it's a little bit longer here. So I'm going to take that out. Open real big. And that actually happens at least half the time. When you screw it in, you can have it perfectly parallel with the eyes. But since the trick of this, the occlusion, let me just show you this when I take it off, is if you notice how we're only engaging or screwing in 2 interfaces, but we've got 4 interfaces hooking, 2 in the posterior. It made a huge difference in the occlusion. And so that allows it sometimes when you put it under pressure, when you screw it in, that's why the cant changes a little bit. Just a hair. See. So one of the things that comes close, let me just push this really up. Hold yours out. That's fine. So what I've affected a little bit is the little Z cuts when you do that, so I'm just going to come back, tweak that a little bit, and then we'll screw this in and we're getting ready for the bite. Actually, that's good. Okay, go very light. Okay, now we open real big when we screw it back in. There we go. Now, let me get the lower one in. I know that's a little tight. We're screwing it down just for a second. Now we're ready to go. All right. So now, let's get the bottom one ready. So here again is the silicone tape or the Teflon tape. If you don't use this, the holes get plugged up, and then you need some kind of instrument to, you heat it up and open it back up again. 2 more screws, please. A little bit wider. Open a little wider. Okay. Now I want to show you a profile. So just stay closed on that. Now close your lips and smile real big. Good. So after these photos, let's take a seat. We're almost done now. We're going to do one last thing. We're going to get a face bow. So the bite material, please. So you can see I'm just getting this ready. I'm taking a face bow, open again. I'm just going to hold that. It takes about a minute. Get this off just for a second. You can shut that off now. So on this procedure,
accept your last case submission.
you know, we try to have it where on a double that the data is scanned in by 4 o'clock. And the reason for that is it takes a good 10 hours for a designer to design double arches. And for their quality of life, our designers work basically from a 4 to a 5 o'clock to a midnight or 1, whatever it takes. So we try to get them on a consistent sleep schedule. When we first started, when we were doing one day earlier, one day later, they were having a hard time sleeping. So we found this really works well for us because, because of the time to mill the restorations, we want to have by at least one arch going by about 11:30 with the millers. So that means if you're doing a double arch, if you can, we start like 7, a lot of times 8 o'clock. So just, we don't know the speed of your office, so just work backwards, give yourself like say 1 hour to do the impressions, 1 hour wait to make the trays. But we can cheat if you get it to us by 5 o'clock. I shouldn't say that. We can still do it. Okay. And why this face bow is important is that if we had to change verticals,
One is not in it.
oh, look at this, excuse me.
Open?
Okay, there we go. Got your side in? All right. There we go. This just takes a second. The vertical allows us, or the face bow allows us to change the vertical, and then we don't open up in the anterior. So if you're using a non-face bow, the way the computer standardizes it is if you open up the vertical a millimeter in the posterior, you're going to be really opening up the anterior about 3 millimeters, and you'll come out with an anterior open bite. So we don't want that. All right, that's it. And then open. We'll get this crazy thing out of your mouth. There we go. So now we have our face bow. And now all we have to do is take our bite. This is an important trick that somebody gave me, or tip. When we do all this work, the muscles have a tendency to get tight. And if you're trying to get into CR, there's a tendency to go protrusive. So one of the things you just want to massage the muscles. So I want to give you a little massage. I want you to open and close. Like watch me like this. I don't want you for a couple minutes. I want you going all over the place. Open real big. Back and forth, really wide. This makes a really big difference on how you can get a nice CR. So real big, go side to side, real wide. Now, we want to practice the bite because it's we don't want to get tricked into somebody going protrusive. This is just Pete Dawson occlusion techniques. Open real big, take your tongue please and touch in the way in the back. That's it. Bite down, lightly, open. Take your tongue touch way in the back. Bite down. So right now I've got the patient, this is a very good CR. And then now one of the tricks, open. Now take your tongue touch on the back. Now if you notice I'm putting only the bite material in the posterior area, not the anterior, because if the patient tricked us, I can tell. Now bite all the way down. Close. Now don't open. Now I'm going to lock this together and go all the way around. And then I'm going to hold this myself because if you have a sedated patient, they can open up a little bit, and then you're up the creek. So I'm just going to hold this. This takes about a minute, and then we're literally all done. Now, before you dismiss a patient, I always check to make sure there's no problems mounting the case because it only takes a few minutes. So I want the patient here in case there was some problem with my technician telling me the bite's off. So again, tomorrow, what's neat, we're going to give, I like to put a patient usually on nitrous oxide, a little bit of local anesthetic because the area is sore. I'll give myself a good 15 minutes for anesthesia. And this case will be inserted and adjusted in just about 30 to 40 minutes. That's how quick it is. So even though, you have to work on this procedure, again, if you watch the surgery, it was about 2.5 hours, hour for the impressions. This took me a little bit longer than normal because I'm not used to being filmed. But this usually takes me, about an hour and 15 minutes to do this procedure. Okay. Open again.
So all involved, you're less than 6 hours for the patient
Yes, and it's all done. Open real big. Get this out.
for a dual arch.
Dual arch. Yeah. And you're done. No, it's not an interim. So now we just got to unscrew this. Now again, trick, make sure you put the protective caps open real big, and I'll get this crazy thing out of your mouth. Make sure you always put the protective caps on. It's amazing how the healing occurs just in 24 hours or 48 hours. When you take those caps out, the tissue's healed where it just opened real big again. There we go. I mean, the restoration just goes right in.